This program is brought to you by Emory University.
Good morning, everybody. Today our speaker is Dr. Devireddy. Dr. Devireddy is the director of the cath lab at Emory University Hospital Midtown. He's also part of our structural heart program, as well as among the leadership for our interventional fellowship program. So thank you again, Dr. Devireddy, for giving this talk.
My pleasure. Kunal was looking for somebody that's most well-versed in horrible complications, and he keeps asking me to do this, so I guess I'm dubious honor. But it's actually a fun topic. I am used to doing this with lots of folks waking up with the sunrise, so hopefully I can keep you awake. If you have questions, how does it work? Are you guys using chat, or just folks can just chime in on audio?
I think either, Chandan.
Okay, sounds good. So I'll apologize in advance. There's a couple videos on this where the files were corrupted from when I had first put these in, when PowerPoint changed versions. So, but it's not for most of them, but just for a few of them. So I apologize in advance for this. So complications after myocardial infarction, if you want to kind of group them into general categories, these would be the 5: ischemic, pericarditic, mechanical, embolic, arrhythmic. And as cardiology fellows, or even as a practicing cardiologist, you know, these do provide sort of a sinister level of fascination for us. And honestly, in the COVID era, we've had a little bit of a reminder of some of these, especially around the months of May and June, where we started seeing some folks come in with some things at a higher frequency than we would typically see just from having deferred care. Ischemic complications, what we'll go into first. Folks can come in with a primary MI, and this infarct can extend if there's further lesions, or if obviously the patient's not revascularized. Recurrent infarction can occur in several different ways. Recurrent angina, we'll kind of talk about all of these. Recurrent chest pain is kind of the bane of the cardiology fellow's existence and may wake you up at night when you're out in practice. Obviously, this is a difficult clinical assessment, one of the tougher chest pain assessments you can have, because your EKG at baseline is already going to have likely ST changes. The key is distinguishing new from old. And just from that last sentence, if you can get old EKGs and put them in chronological order, that's often going to help you. When patients are hospitalized after an MI, they may also have alternative physical complaints. You give them a big load of dual antiplatelet, and that may give them heartburn. You know, patients are in bed, they may start getting shoulder and back pain. I mean, there's a number of things that can happen. And again, you have to kind of sort through the weeds to figure out what's real and what's not. Patients who are diabetic, or just present atypically to begin with, may have recurrent infarct or ischemia, and they may not give you the classic symptoms. Also, if a patient presents with a large infarct, they may also present with a number of the complications that we'll talk about. That can occur both from infarct or from hospitalization, such as aneurysmal change after a massive MI, pericarditis. And again, you know, going through sort of the algorithm, a good history and physical exam is going to help you distinguish these. So with that being said, what do you do? I put this in bold, especially as we're now in the world of telephonic triage and even Zoom and whatnot. It's really good to get out of bed, drive out and see the patient, especially when the stakes are high in a post-MI setting. You know, it's one thing if you've got someone coming in that's a really atypical chest pain in the ER and you're sort of triaging, but post-MI, you don't want to mess around with these because you may miss something big. And oftentimes the intervention here may be simple, but if you make the wrong call and don't see the patient, you may have huge buyer's remorse the following morning. The easiest thing you can do is repeat the ECG or several EKGs over a short period of time and just get a sense of trend, both in waveform, rhythm, and whatnot. You could do simple maneuvers, such as looking at the response to nitroglycerin, what's the patient's hemodynamic status. And you guys are well versed in all of this. Recurrent infarct, As I mentioned, with primary PCI and revascularization, we don't see this as often. When we do see it, maybe more often when we have patients present with multiple plaque ruptures, which may sound strange, but we probably see a few of these a year. And this has been well documented in several studies that patients may present with, let's say an anterior MI that's obvious on an EKG, that revascularized, but when you're in there, you may say, well, it's kind of funny, this distal right looks very hazy, and I'm not sure what to make of that, but there's TIMI3 flow, so you leave it alone. And then lo and behold, later on that evening, you have a patient present with inferior ST elevation. It may sound, like the same odds of getting a lottery ticket win, but we do actually see this probably once or twice a year. Sometimes with the plaque actual rupture and complete TIMI0 flow in two, I've even seen 3 vessels. So just having that level of suspicion to look for this. The IRA, or the infarct-related artery, despite restoring TIMI3 flow, may shut down again. And there's several reasons why this could happen. One is that the artery itself may have had some complication that was subclinical, not recognized, such as an edge dissection or tear, proximal or distal to a stent that was placed. A patient may have an underlying hypercoagulable disorder, and despite being on the hospital-ordered dose of heparin and dual antiplatelet, may still thrombose a stent, or a patient may not have received the dual antiplatelet, which may happen as well, especially in a patient, say an inferior MI patient comes in, gets profoundly nauseated, hacks up everything that is in their stomach, including several tablets of clopidogrel or Brilinta or whatnot, and that may not be recognized by the nursing team, and you find out 4 hours later when the EKG shows that the STs are back up. So just, again, having the level of suspicion for all these different possibilities will help you run the list in your mind when you're woken at 2 o'clock in the morning to figure this out. Coronary spasm is unusual, but just something to think about. And obviously, intervention with nitroglycerin can help you assess whether this is involved. What things may increase the incidence of a recurrent MI after a primary insult? Sort of things that you would think about that would make an MI worse in general. Patients who are diabetic, higher kill-up class, and as I mentioned, a challenging PCI, let's say a stent that's placed in a artery that has a significant size mismatch or diffuse disease, or had a huge thrombus burden to begin with. These are some factors that may lead to a poorly expanded stent, or a stent that may have part of the stent that's floating in the vessel that wasn't adequately opposed to the wall, and that can lead to thrombus. So we talked about diagnosis. Getting another EKG is sort of your hallmark. If you have significant recurrent ST elevation, that should raise your suspicion. If you have the same degree, but more typically, you might see it at half the level of ST elevation that the patient presented with to begin with, it's probably unlikely that this is a recurrent problem. And it's not uncommon for a patient with a STEMI to have persistent ST elevation, but at a much lower level, less than half of the initial elevation. But if you're back to the same level or higher, obviously you got to think about this. If this patient has both that, and you're getting the call that they're in cardiogenic shock, and you start thinking about starting pressors, then you really need to go into overdrive and get yourself there quickly to handle this patient, because they may go down quickly. Cardiac markers, back in the old days when I would come into call on a horse-drawn carriage, we would really evaluate cardiac markers in serial fashion. It's questionable whether this gives you a lot of benefit, because these are going to be elevated for that first 24 hours. Now, unless they were already coming down and you actually track this trend, it's probably not going to help you too much. I mean, you can get them, and I'm a big fan of following the troponin over time, just so you know that you're on that downward slope of the MI, but in the acute triage setting, it's probably not going to give you too much. This is just a overall chart of kind of how to think of this in terms of a flow chart. And a lot of this is what we've already talked about. Pericarditis, again, all of these that we're going to talk about, we don't see very often, but you'll probably see, especially as a fellow, one or two of these per year. If you see a pericardial effusion, and our patients are never ecopenic, you're going to have lots of imaging, peri-MI, post-MI, and you may see effusions. The presence of that is not implying a pericarditic complication. It's more the clinical presentation, and you can have significant post-MI pericarditis and have no visible effusion on an echo. It's just all about having that level of suspicion. And this presentation may be anywhere as soon as the 24 hours after, or can present 4 to 6 weeks after. Just depends on the severity of the infarct and the patient's inflammatory response. How are they going to present? Pretty much, classic as you would expect for a textbook pericarditis. You got to think about positional change when you're getting your history, relationship to inspiration. On physical exam, you may hear freight train type of rub going down the tracks, but the lack of a rub, again, does not exclude the possibility of pericarditis. So again, just have that level of suspicion even if you don't have it. But obviously hearing it can help you clinch this diagnosis. And if you do hear it, it may impart a worsened prognosis overall for this specific infarct. If the patients are on anticoagulation for any reason, if they have another condition for which they're on it, or you're treating them, let's say they have an apical aneurysm, as we'll talk about later, you may think about a temporary hold on this just for the possibility of a hemorrhagic transformation. It's not guaranteed, but there's a relative indication to think about this. The management of pericarditis has changed a bit in the past several years. One thing you want to think about, especially in the post-MI setting for healing, is to avoid steroids. There is some thought that high-dose steroids may predispose to lack of healing from the injury, possibly even some of the other mechanical complications that we'll talk about, such as septal rupture. You want to avoid other types of NSAIDs, except for aspirin, which you're going to use at high doses. And when we take high doses, we're talking, 4 to 5 baby aspirins every several hours. The use of colchicine has really experienced a renaissance, especially this year with a lot of data that's been presented that hopefully you're all familiar with. I didn't include those trials because they're more of a general prophylactic measure in patients with NMI, but if you've actually developed this inflammatory syndrome, then I think the use of colchicine would definitely be something you'd want to think about. Dressler syndrome is sort of the peak of severity of in terms of presentation with post-MI pericarditis, is what you'll see in the pathology textbooks. This is typically going to occur weeks after an MI, not in the first few days. And again, we don't see much of this anymore. It's a very profound immunopathologic syndrome that if you were to look at the fluid or the pericardial layer under a microscope, you'll see a ton of polys. You will usually see a pericardial effusion here. Patients get very sick, feel like they're having the flu, can be febrile, inflammatory markers will be elevated. And again, here you're going to treat with high-dose aspirin and consider colchicine. Cardiogenic shock, this is, of everything we're going to talk about, the one that you're probably going to see the most and that you really need to have the most familiarity with in diagnosis and in treatment. The folks like Kunal Bhatt are going to make you guys experts in this by the end of your fellowship. When this happens in the setting of an MI, most of the time it's from failure of the myocardium as a mechanical engine, as opposed to us blowing a hole in a valve or a wall of the myocardium. We may see a little bit more mechanical defects than a typical institution, just because we get a lot of VSDs and whatnot referred to us. The incidence of this has increased slightly over the years, about 1 in 10, and especially at tertiary referral centers, you're going to see more of this. The predisposing demographic features are what you'd expect. Patients who are older anterior infarcts, diabetics, and obviously prior infarcts. How these patients are going to present, hopefully you're all familiar with cardiogenic shock, but you're typically going to see patients who have started down this sort of cascade of going down the drain with elevated filling pressures, reduced cardiac index, which then further reduces coronary perfusion and so on and so forth, and you're going down the spiral. Blood pressure lower than lower than 30 minutes. We've done better, but these patients still carry a very high mortality rate overall. So we're trying to be much more aggressive in recognizing this earlier and putting into place all the interventions to keep them from going down this vicious cycle. As you can see here, overall, we're seeing more of this. This is kind of older data now, but mortality, maybe we've done a little bit better, but not by huge leaps and bounds. So again, thinking about pathology in patients who have this in the MI setting, a lot of these patients are going to have significant coronary disease, many times 3-vessel disease. And again, it just makes sense if you think of the heart as a mechanical engine, that the more of the functioning myocardium you lose, especially if you're going over 40–50%, the higher the chance you're going to run into this. Isolated circumflex infarcts, unlikely. Isolated right coronary infarcts, unlikely. And if you do see cardiogenic shock in that setting, you may want to think about other things, as we'll talk about later, such as RV infarct, papillae muscle rupture, tamponade, all these other things. So just have that, because the treatment of those are very different. So you want to make sure you keep those differentials in your mind, so you just don't assume that it's a bad MI, you're having cardiogenic shock, you just need to start pressors and whatnot. The other rare diagnoses are treated very, very differently. How can you make this diagnosis? Getting a quick bedside echo is what's going to really help you the most. And paying attention not just to ejection fraction, but taking a look. Is there an effusion? What does the mitral valve look like? What does the right ventricle look like? And just going through very quickly through each of the different views, the different mechanical aspects of myocardial function, so you've covered the bases. And again, we talked about preventing this downward spiral. How do we treat these patients? Medical treatment is the hallmark of an early intervention. You want to use the proper medicine at the lowest dose needed. Patients who are very sick, placing a PA catheter can help you in terms of looking at some of the data with wedge pressure and outputs and titrating to specific filling pressures. There is data that, and we'll look at some of this, but norepi is probably the pressor of choice as opposed to some of the other agents. You really want to avoid alpha agents here. You don't want to increase afterload with peripheral vasoconstriction in the setting of an MI. So really trying to maximize your output and give you some level of baseline blood pressure improvement. This is a very busy slide, but basically the message here is that there isn't a whole lot that we have in clinical trials that are clearly shown to be better in the setting of shock, except for a few things. So if you look at these specific trials, and this may have come up a little funny, but culprit shock, let me go back here a second. So culprit shock is a recent trial that said, we know now that focusing on the culprit lesion for an MI, those patients are going to do better than if you're immediately going in and trying to revascularize everything. There's a couple of reasons for that. Some of them may be related to the contrast dose, but we know those patients do better, as you can see here, as far as the confidence intervals. Vasopressors, again, this is interesting, which essentially shows that norepi looks to be better than dopamine or epinephrine. So this is very interesting that we do have some trials that actually bear this out compared to some of these other trials. A lot of this other stuff is smaller stream stuff, but you can see here, everything else is pretty much right on the confidence interval line. Main management of shock, if the patient comes in with acute MI, they're in shock, have they been revascularized? If they haven't, that is your mainstay of benefit. That's where you're going to get your long-term mortality, and that's why we focus so much on door to balloon. There's no patient that's going to benefit more from a faster door to balloon and an appropriate revascularization than a patient post-MI and cardiogenic shock. I should say post-MI, peri-MI. And this obviously is a class 1 indication to get these patients in, get them revascularized. Now, whether there's, and we'll kind of go into some of the adjunct devices, but patients, here, you've got the overall Kaplan-Meier curves for revascularization early on versus just medically stabilizing them. And you can see there's an early split and it's sustained with patients undergoing early revascularization doing better than patients on medical management. If you carve into the data a little further, you can see that there are some subgroups that do better. So if you have a patient who's 85, coming from an assisted living facility, may be able to participate in bingo, but otherwise is doing a whole lot. If they're in cardiogenic shock, it's not a bad idea to take a step back, ask the questions. Well, what does this patient do at home? What is their functional status? It may seem counterintuitive when you're trying to race to a door to balloon time, but taking that kind of a discussion, if you document it properly, those patients will be excluded from your door to balloon metrics. So you shouldn't race to revascularize a vessel just to make a door to balloon metric. You always have to think about doing the right thing clinically. And as long as you document it, oftentimes, if you have difficult medical decision making, and it's documented, and it ends up taking longer than the 90 minutes, as long as you had a good reason for that, it's okay. But obviously, you want to get these patients in quickly if they're in shock. So you got to, really think about this. But when we do our monthly review of quality metrics for PCI and MIs, it's oftentimes these type of patients. A patient who comes in 85, 90 years old, anterior infarct, they're in shock, and the initial gut reaction is, okay, well, we got to do everything. We want everything done for grandma. And then more often than not, we're reviewing a mortality event, 12 to 24 hours later. Because these patients, when they're in shock and this old, they typically don't do as well. Now, patients who've had a prior MI, if they've come in fairly quickly, less than 6 hours, you're really going to get a big bang for your buck in getting these patients revascularized. But compared to just a standard MI, even if the patients are come in the first as late as 24 to 48 hours after the initial onset of chest pain, and the onset of shock is less than 12 to 18 hours, you can still have benefit in these patients. So you may extend the window that you would classically think about for revascularization if they're in shock. And the thing I want to preface here is that I'm not saying that you need to have a death panel when these patients are coming into the ER, that if they're over 75, you're not revascularizing them. I have a lady I just saw in clinic this week who's 96, and she's 4 or 5 years out from her STEMI. She came in, we kind of talked really quickly. Asked, what do you do? Well, I spend most of my time reading. And this lady reads every single book you put in front of her. She was still smoking, believe it or not, at 92. But she obviously was mentally very sharp, was with it. We went in, radial access, got a great result, and she's still smoking and still reading lots of books, even though I try to get her to stop smoking. So you got to individualize everything, obviously, but think about it in the back of your mind. So this is sort of the sexy topic we think about from cardiogenic shock. What kind of devices can we put in patients? Large bore devices that make lots of noises and pump lots of blood. Here are your choices right now. We've got the tried and true balloon pump in cartoon A, the Impella device, which a lot of you are familiar with. Tandem heart, many of you probably not have seen, that involves a septal puncture and actually rerouting blood from the LA and then back into an arterial circuit. ECMO, we're seeing more and more of. And then there's also the right-sided Impella, and we'll talk about in a little bit. Balloon pump was the first kid on the block. Currently in the guidelines may even take this down further in the future, but there's a lot of debate about whether balloon pumps should be as maligned as they are now for some of the data that we'll talk about. Impella is sort of the Cinderella at the ball right now, and they spend a lot of cash flow in marketing. as I can attest to the many emails I get from them. Tandem heart is more of a specialized device, and ECMO you're going to see at tertiary centers. So there was a SHOCK 2 trial, which was the largest randomized controlled trial performed in the setting of MI. A number of patients, as you can see here, were enrolled. However, it was still below the statistical power needed to really detect a treatment effect. So it was, as you can tell, it must have still been a challenging enrollment. Even though they got 600 patients, it wasn't close to that. Almost all these patients underwent revascularization, and patients who had a balloon pump in had it for a median duration of about 3 days. And to the chagrin of many folks in the balloon pump camp, there wasn't much difference at all between revascularization and optimal medical management and patients who got a balloon pump. So this is several years ago now, and the Impella camp really went after these guys and said, look, balloon pump doesn't do anything. And as I'll say here in a second, there are some patients where a balloon pump probably doesn't do much. But does this trial really spell the end of balloon pump? Well, as with everything, you got to look at it with a grain of salt. So there are a lot of questions when you parse the details of the trial about, well, what was the real severity of the patients who were enrolled? Were the patients who, in rip-roaring shock, were the operators and the investigators really comfortable in randomizing those type of patients? Well, probably not. The patients who were included were probably much more of a mild to moderate presentation of shock with just a borderline blood pressure under the definition of shock. In the medical management group, there was crossover, which, especially with a smaller sample size, is going to kill your ability to detect a difference. And, there's a question of whether a lot of these patients required a balloon pump until after the PCI. Again, you're selecting for a different type of population. And many of these patients weren't true STEMIs, but were non-STEMIs. So I want to put this was a Twitter, if anyone follows me on Twitter, I apologize. I've probably gotten more political than medical in the past year. I've actually taken a Twitter break for the last couple of weeks. But I had an interesting interaction here where I just had this kind of fun case, posted it, where we had a patient who presented with TIMI2 flow and an LAD, and the patient suddenly became hypertensive on the table. So in this setting, we really wanted to move quickly, threw a balloon pump in, put a bunch of metal stent in the LAD, patient at TIMI3 flow, blood pressure came up, we all high-fiving, we're heroes. And for whatever reason, I posted that our happiness on social media. And I get this response. The main value of balloon pump is that it makes a reassuring noise, which helps to calm the operator, which is exactly what a lot of folks were saying after this SHOCK 2 trial. So then I responded, well, in this case, I was even more reassured when the noise raised the patient's blood pressure by 40 points. And then it was kind of funny. The same guy then replies, in sort of this, bearing his inner soul. I actually confess to a conflict of interest. I use balloon pumps regularly, but the supporting data is limited and effects are blunted in sick patients. Maybe the correct trial has not yet been done. Then Pablo, who's a good guy, says, agree, what's been proven is a lack of effectiveness of systematic use of balloon pumps in shock. So I think this brief little interchange kind of spells out the role of balloon pump in 2020. So it's not your default device, but if it's all you have, or if your patient is limited in terms of their vascular access, I don't think you're wrong in using a balloon pump. I think all of us in the cath lab world, in the structural world, we still regularly use balloon pumps, but in selected cases. Oftentimes it may not be for the same degree of shock as what we would use in an Impella situation, but there are risks to the other mechanical devices, as we'll show here in just a second. So when to employ mechanical support? If you cannot get your patient revascularization without it, you got to put something in. Otherwise, you are holding back the benefit that is most likely going to result in decreased mortality. If your patient is unresponsive to initial pressors and your initial interventions, start thinking about it early, because it's all about getting them off that spiral. It's a horrible slide, and if if the voice in the back of your head, and you always want to listen to that voice in cardiology, if your inner angel on your shoulder tells you, you know what, time to think about pressors and a mechanical device, listen to your voice. The problem is we don't have a lot of studies that are well designed to really show anything, what the difference is between Impella and a balloon pump. So it's going to come down to what is your hospital's experience in placing large bore access and placing Impella in the care team managing the Impella after it's placed. But currently Impella has been able to get FDA approval for this indication as opposed to the balloon pump. And there's been a number of centers that have done some interesting things. The folks up in Detroit started what's called the Cardiogenic Shock Initiative, and they have this kind of algorithm of how to think about the decision-making of placing an Impella. And in their algorithm here, they say to get specific measures, which you can get very quickly when you're in the cath lab. What is your end diastolic pressure? Is it over 15? What's your cardiac index? And maybe it's worth taking the time to stop, put this in, and then go ahead and proceed with your coronary revascularization. If you try to be too cowboy about this and say, well, I'm just going to open up the vessel, and I'll just deal with the hemodynamic questions later, and you end up with a no reflow phenomenon or a dissection of the vessel, then you're up a creek without a paddle, because then you've got a patient who's already in shock, and now you've completely shut down or embolized material downstream, and you're in trouble. And there's a couple of measures to think about, which is cardiac power output and the PAPI index. These are very simple measures that you can obtain with a right heart catheterization. So again, have a low threshold to get these measurements, and helping you kind of titrate support and to think about placement, or whether you need to get these patients to even further support, such as LVAD, ECMO, whatnot. Now, as I mentioned, there's not great data, but there's been a little bit of data looking at comparing Impella versus balloon pump, and the signals they show are actually very interesting. So these are, again, small sample sizes. Timing of therapy was at operator discretion, but mortality was pretty much the same. And what they saw was that there were more complications, such as bleeding, vascular complications, hemolysis, in patients who get Impella. So just because you're getting more cardiac output with an Impella doesn't mean that these patients are just going to do better by default. There are other problems that come around with the use of Impella. And this was shown fairly elegantly with one of our current interventional fellows who came to us from Mayo Clinic. Saras, for those of you who met him, just published this last month with his prior team members at Mayo, looking at acute MI patients in cardiogenic shock, and looked at patients, so not randomized, but they looked at patients who got Impella, who got a balloon pump. They did propensity matching, and as suggested in the other trial, there were higher complications with percutaneous LVADs or Impella. In most of these cases, it was Impella. The blue bars are the Impella, the red bar is balloon pump, and if you look at all of these, there was a statistically significant difference with a higher incidence of complication. Vascular complications are worse. Hematologic, most of the time this is coming from hemolysis, higher incidence of stroke, acute kidney injury. Maybe a little counterintuitive, but I think a lot of this is in patient selection, and again, in proper placement and proper management. Once you put the Impella in, the game's not over. You have to recognize whether it's in a correct position. If you see hemolysis, are you doing something about it? If you just say, oh, well, that's just what Impella does, then you may end up in trouble, because the device either has to be repositioned or you got to take it out, because you end up with significant hemolysis with an Impella. These patients can actually chew up a lot of blood very quickly, and that can be a really big problem. Patients who got Impella had a complication compared to balloon pump patients with complications, as you can imagine, had higher mortality and had higher cost to the healthcare system. So food for thought there. There's some other thoughts in terms of thinking outside the box of whether there may even be benefit in putting in a percutaneous LVAD and just unloading the ventricle when there's significant shock for, let's say, 30 minutes, and then proceeding once ventricular filling pressures have been lowered. There's some animal data that suggests that there may be benefit here, but there are trials ongoing to really demonstrate whether this is clinically beneficial in humans with a decent sample size, and we'll have to see as we get more information on whether there's anything to this. So moving from what we think of as cardiogenic shock from the left ventricle to the right ventricle, RV failure can give you very refractory shock, and if it's not recognized, can get you in a lot of hot water because these patients can go down very quickly if you don't do the right things. And even if you do the right things, it can be very hard to treat these patients. So many of these patients will have shock, have clear lungs, their JVP will be up to the mandible. If you get a right-sided EKG, you might see these type of changes, but it's not guaranteed. So you have to have that clinical level of suspicion. Echo is going to be your key diagnostic strategy here. Do you see a blown out RV? And if you do, then you're going to manage these patients very different than LV shock. You're going to really flood them with fluids. You're trying to maintain preload. The worst thing you can do here is diurese these patients. Having, invasive hemodynamic monitoring can be of help here. If these patients, for any reason, are in heart block or whatnot, you want to restore AV synchrony because that just by itself can take a lot out of these patients. You can think about dobutamine, and obviously coronary perfusion is going to be your mainstay. Most of the time, these are big right coronary arteries, proximal RCAs. You can get these open. You can get these patients better in the next 12 to 24 hours. There is an Impella equivalent for the right ventricle. It's a little bit trickier to place compared to the left-sided device, but it can be helpful. I will say that, the patients who we use this device in typically are so sick that we oftentimes wonder about how big a difference we're making because their mortality rate is so high. But we have had a few saves with this, so it's just something to think about. It's a venous device that you need a stiff wire to get this over into the pulmonary artery. It has a different curve and shape to it, but can provide cardiac output support in the setting of RV shock. So this is a very busy graph here, but just kind of shows you that not everybody is going to need mechanical circulatory support, which is what MCS stands for here. If you have cardiogenic shock after an infarct, you kind of dissect these patients into different groups. About 50 to 60% of patients will have survival without the use of these devices. About 40-50% of these patients are going to die, many, no matter what you do. So you've got this small group here, about 15 to 25% of these patients that may benefit with the use of the MCS. What's hard for us now is, identifying factors to clearly sort of identify which cohort patients are going to be in when they first present with cardiogenic shock. But the only reason I put this here is to just outline that the use of an Impella or balloon pump is not going to be a guarantee of victory here, that a lot of these patients are going to die. And it's a very difficult patient population to work with. But if you don't do anything, if you don't do the diagnostic workup, you may end up with more of these patients in the no survival group. All right, so now going into some fun stuff. Looking at mechanical complications, these are sort of very amazing to watch from just an objective observer standpoint, but these can be horribly bad or very sad stories. Ventricular septal rupture, these are some, we've seen a lot of these in the past couple of months, as I mentioned, in the COVID era. Same sort of risk factors as you'd imagine, large infarcts, big anterior infarcts, oftentimes patients that just did not have the ability to collateralize. Folks, oftentimes in the early days of training will think about these as you do as a congenital VSD, but it could be further from the truth. These typically don't follow any even path or shape. These are often very irregular, serpiginous tears through the septum. If you have an anterior infarct, it'll typically be in the apical septal distribution, inferiorly basal septal. Sort of the hallmark board question physical exam finding is a new, very harsh holosystolic murmur, may have an accompanying thrill. That they're very dramatic murmurs. at the left lower sternal border. And you'll see with most of these complications, there's a bimodal incidence. If it's drastic, you may see it as soon as the first 24 hours, then the incidence declines, and then there's a higher peak at 3 to 5 days post-infarct. And as with all of these, high mortality. This was a patient that, that's one that doesn't play, but there's a huge defect here, as you can see through color flow. Biventricular failure here began very quickly. Supportive care is not going to rescue these patients or fix them permanently, but they can afford to serve as a bridge. And that bridge may be just the amount of time to let this heal so that you can do something else, whether that's surgery or sort of an outside the box transcatheter device to plug or close this. If you don't do anything, it's probably a guarantee that these patients are more likely going to die than anything. So an Impella here can help to a degree in just biding some time, because the more time you allow these to heal, the more chance that you can put sutures through it or have a device hold. And in that case, it's a patient, 77-year-old who was a prior smoker, prior AAA rupture, presented with an infarct for a week prior to presentation, had that same kind of murmur, was cath, had found to have severe LAD disease, and was found to have a VSD. Was transferred in fairly late. This is not that typical. If they come in a week or two and you can get them out past 2 weeks, the surgeons and we in structural heart world are much happier, because you can oftentimes use a transcatheter device to do surgery. There's some novel techniques that structural team at Emory has pioneered. Some is actually even kind of trying to button and use the right ventricle as sort of a plug in addition to the transcatheter device to help seal these holes, and we continue to try to innovate in this area because these patients do so poorly. But there are options if you can buy some time. There's an example of just this huge defect right here. I think this one actually one of the few ones that plays. Here in MRI, you can see a very clear picture of the defect here and right here. In this case, I think this patient did undergo closure with a successful result. Free wall rupture is just sort of a variation on the theme of septal rupture. And patients who present with this may come in with just sort of a nagging pain a week after an MI, or just suddenly it's almost like snapping their fingers. They say, I was doing fine, and all of a sudden I just had this massive pain in my chest. And so there's no classic presentation. It's all about the level of suspicion. So how do you get these patients to survive? Well, it's low likelihood, but you got to do something. So supportive care, you're trying to bide some time to get them evaluated. So we do use mechanical assist devices here. And again, if it's a fresh infarct, sometimes it's just like putting sutures through jelly. The ventricle just tears away and melts under your fingers. You need to monitor these patients very vigilantly for tamponade in case you need to do a pericardial centesis and evacuate blood. Obviously, that puts you in a tougher situation. And having a low threshold to get a structural heart team, cardiothoracic surgery involved so you can get their opinions early on. One case, 75-year-old gentleman, multiple vascular history, had chest pain for 3 days prior to getting an echo, was at the VA and showed a new occlusion of a vein graft. Patient was transferred for high-risk PCI. Patient was going to have persistent chest pain, had lateral EKG changes, and was stented to the native circ. And then it was realized this patient probably had, because the presentation was late, had a rupture. It's hard to see here, but there was a full defect here, as you can see, kind of a gap in the myocardium. Sorry this doesn't play, but big lateral rupture. Again, as I said, these are all variations on the theme. Papillary muscle rupture. The two classic infarcts that will present with this are an inferior MI, where you affect the posterior medial head of the mitral valve. This is the most common. An anterolateral myocardial infarction will involve the anterolateral papillary head. If you truly completely transect the papillary muscle, it's typically a fatal outcome. What will happen more often is you may snap one of the cords. So you'll see kind of a little floating little pyramid flapping around the mitral inlet. But losing an entire papillary muscle is a big problem. So that typically is not what you're going to see. You'll see one of these kind of snap off, and you end up with a significant prolapse of your leaflet. Patients may present with a new systolic murmur, but sometimes the mitral regurg is so complete that there's just not that much of a pressure difference, and you may actually not have as impressive a murmur as you may think. So just the absence of a murmur doesn't exclude this diagnosis, but it's the refractory heart failure that should clue you in. If you have a patient that suddenly just gets horrible pulmonary edema, a cardiogenic shock, comes out of nowhere, get the echo, keep in your mind, what does the mitral valve look like? Because this is a very common complication if you look amongst patients that have mechanical complications. So if you look at, the Robbins pathology textbook, this is kind of what you see. This is, a free wall rupture from the outside of the LV. Here you've got evidence of a septal rupture, and here you've got a complete transection of a papillary muscle. Unfortunately, this doesn't play. Basically, what this showed was just, you can see that the cord and the papillary muscle head just kind of flying around and significant mitral regurgitation. One case that case with the echo was a patient who had had chest pain for several days. Troponin was elevated, but it was felt to have been something possibly late. For whatever reason, the patient wasn't initially cath, but then had a sudden clinical decline. Echo showed severe mitral regurg. Patient was taken for cath, had a complete occlusion of the left circumflex. This was long enough ago that the patient received a bare metal stent, had a balloon pump placed, and was actually taken emergently to the operating room. In the OR, they demonstrated severe MR, fractured head of the papillary muscle with a prolapsed P2 of the posterior leaflet. That's kind of classically what you're going to see, 1 week after infarct in this sudden decline. So this sort of separates these ruptures. They're all very similar. As I mentioned, incidence is low, about 1%. All of these are going to have a bimodal presentation, first 24 hours or about a week after presentation. Clinical presentation, you need to have all three of these on your radar because they may all present somewhat similarly. Papillary muscle may be much more profound pulmonary edema. Many of these patients may have new murmurs, specifically in VSD or MR, but the absence of it doesn't necessarily exclude it. And the key thing is just having a level of suspicion. So what can we do with some of these ruptures? Again, as I mentioned, you want to get these patients with early inotropic mechanical support, call your surgeon, and the longer you can postpone, if it's possible, the greater the chance you'll have scar that you can work with sutures or devices. But of all these patients who present, it's probably less than a quarter who can actually wait that long. So oftentimes we try, and in probably less than half of cases are we able to give them some type of durable solution. Pseudoaneurysm is a little bit of a different presentation. This may occur in the setting of an LV rupture that somehow manages to seal itself with the surrounding tissue. It's not a true rupture of all layers of the myocardium, but more of just, you've got a rupture, but then you've got this aneurysm that's actually formed by the clot in the pericardium around the MI. These can grow to become huge. You can get a big clot burden. These can embolize. LV function can be significantly impaired from this. And this has been an area where some nifty surgical or transcatheter devices have been able to close these, but you want to get these patients in quickly so you don't actually get a full free wall rupture and full tamponade. So this is just a cartoon depiction of how an aneurysm differs from complete enlargement of the the LV versus just a focal blowout, and then this sort of pseudo aneurysm cavity that develops around the ventricle. You get a large burden of clot inside these. You can get clot in an aneurysm as well, so you have to think about that with both of these. Much higher risk of rupture in the pseudoaneurysm setting. So this is an example of an apical aneurysm, you see the entire apex is dilated and thinned out right here. Again, you see that here, thin. You may see scar in these. You may see a clot. You don't see it here, but you may see clot adherent to the apex. Sometimes you need echo contrast to distinguish this. But a pseudoaneurysm, as you can see, is very different. You have what kind of a normal appearing apex, and then you've got this huge spade, in this case, which is formed from the surrounding tissue. So if you see these, can you reduce the chance of incidence of thrombus and embolization? This is a little bit controversial. In patients who have clot that has been documented, we can reduce the chance of embolization. If you see a thrombus early on, these patients typically are going to have a poor prognosis. It's not guaranteed that it's going to embolize, but it could be as high as 10%. We have limited data on how to treat these patients, but when we do see clot in the apex, typically putting these patients on warfarin for several months is going to be helpful. But again, that's in the setting of a proven mural thrombus, even more so if there's been a documented embolus. And the type of MI you're going to see these in are classically a large anterior infarct with a blown out apex. We had one case, 88-year-old lady, presented with a stroke. She got TPA for the stroke, and then an echo was found to have a huge apex, like what I've shown you before. Was a visualized LV thrombus. There wasn't a huge troponin, but the presence of that thrombus was enough to break off and cause further mischief. And you can see here, you see this density that's adherent to the apex here, and unfortunately these can break off and cause trouble. Now, if you see an aneurysmal apex but no thrombus, well, can we prevent events like stroke or recurrent coronary emboli with prophylactic anticoagulation? Well, there was a trial done a couple of years ago that looked at 460 anterior STEMI patients and randomized them between dual antiplatelet and warfarin triple therapy, which you can argue that this is a little bit out of date now because we know that triple therapy is probably not as good. But overall, if you look at the no warfarin group, the incidence of some of these complications, there's no difference in stroke. As you can see, there's a higher incidence of bleeding in the warfarin group. But as far as hard outcomes, the patients in the no warfarin group actually did better. So in the absence of a visualized thrombus or an embolic event, just having an apex does not mandate the use of systemic anticoagulation. But as in everything, you have to individualize this, but you have to realize there are complications from the use of warfarin, specifically triple therapy, which you could argue may have been one of the problems with this trial. But we're typically not prophylactically anticoagulating these patients. Arrhythmic complications, you can have an entire EP lecture on this. Basically, any rhythm disturbance you can imagine can be seen in the post-MI setting, but some are more common. And this also, as with everything, depends on the location of infarct, the extent of damage, the presence of shock. And these rhythm changes can be significant because they can decrease the cardiac output, as we mentioned before. The loss of atrial kick, recurrent non-sustained VT may be much more significant to a patient with reduced cardiac output than to someone who has a normal LV function. This is one just to think about for the boards. If you have a patient that you've opened up the coronary, it's not uncommon in the first couple minutes or even the first few hours to see this sort of rhythm, which we call idioventricular rhythm or reperfusion arrhythmia. It's typically regular, a little bit of a widened QRS, and is usually self-limited. This is not VT, and typically is a sign of restored patency. If you see this, especially immediately after revascularization, you don't need to treat this. Just kind of observe and take a closer look to see what's going on. So we've gone through a whole whirlwind tour. I hope I'm finishing you guys right on time. So this is just kind of the way you think about this. And again, just to recap real quickly, if you get patients with cardiogenic shock after MI, you want to think about getting these patients to the cath lab, getting an immediate echo, differentiating these. Is it LV shock, RV shock, or mechanical complication? The treatment of all these is going to be very different. Obviously, with mechanical, you want to think about revascularization. With power output, with RV dysfunction, LV dysfunction, you want to think about revascularization. With mechanical complications, getting them revascularized, it can also be helpful, but typically it's not going to reverse this change. So you need to get a CT surgical or structural heart evaluation early on. And then there's a lot of things we talked about, in terms of whether it's LV or RV, hemodynamic monitoring, the type of pressors. We're going to prefer norepi over the others. And then if patients are not responding, balloon pump can help if you have nothing else, and you can get the balloon pump in very quickly. But if you have a pathway to getting a more sustained mechanical support device like Impella, if it's selected patients in a center that has good experience in doing these safely, then you may get benefit. So I'll end there. Just a minute over time. If you have any questions, I am happy to take them.
The preceding program is copyrighted by Emory University.